Good morning, everyone. I am Dr. Amit Kumar Soni, Assistant Professor of Cardiology in UN Mehta Institute of Cardiology, Ahmedabad. Today, we will discuss the 2D echocardiographic evaluation of mitral valve. So, how do we assess the mitral valve? Coming to the first mitral valve anatomy, so mitral valve anatomy includes the leaflets, annulus, subalveolar apparatus, papillary muscle, and the chordae tendineae. So you can see in the diagram that there is a mitral valve and the chordae, papillary muscles, and LV. So this all included. So mitral stenosis is the most common valvular heart disease encountered in developing countries. The incidence of isolated mitral stenosis is about 25%. Combining with the mitral stenosis and mitral regurgitation accounts for 40% of the cases. Associated aortic valve involvement is seen in 35% of cases. So etiology of mitral involvement is most commonly rheumatic is most common as we have discussed in developing countries, and severe mitral annular calcification is second most common etiology. Third is congenital, including the parachute mitral valve, single papillary muscles to which the chordae and both leaflet attaches, results in a mitral stenosis of mitral regurgitation and supravalvular mitral ring. And the fourth is least common, that is a systemic disease involving the mitral valve, like carcinoid and SLE, rheumatoid arthritis, and healed endocarditis, rarely carcinoid diseases. Other MS mitral stenosis like physiology is myxoma and valve thrombus. So coming to the most common etiology, rheumatic mitral stenosis is commissural fusion is the main mechanism, caudal shortening and fusion, and leaflet thickening, superimposed calcification later on as disease progresses, and annular calcification and restriction of motion. So main mechanism is commissural fusion. Degenerative mitral stenosis main mechanism is annular calcification, leaflet thickening and calcification at the base, rarely, and no commissural fusion. So here is a main mechanism is annular calcification, seen in elderly hypertensive atherosclerotic disease patients and sometime in aortic stenosis patient. So this is how degenerative mitral stenosis look like and how rheumatic MS looks like. So we can see there is a annular calcification, and in rheumatic MS there is a caudal commissural fusion. Congenital MS is a subvalvular apparatus abnormality is a main pathology. In systemic MS, leaflet thickening and restriction are the most common, and commissural fusion is very rare. Supramitral ring, this is how it look like. Parachute mitral valve, there is you can see that there is one single papillary muscles, and this leading to the mitral stenosis and mitral regurgitation both. 2D echocardiographic view to assess the mitral valve is parasternal long axis view, short axis view at the mitral valve level, aortic valve level, and four chamber view. Coming to the parasternal long axis view, we can assess the leaflet thickening, restricted and typical diastolic doming of AMBL, hockey stick sign, known as hockey stick sign, calcification, caudal thickening, restricted mobility, associated mitral regurgitation. So this is the parasternal long axis view of mitral valve, and there is a mild mitral. M mode, how it is helpful for assessment of mitral valve. Then first is dense echo on the mitral valve, decreased DE excursion, poor leaflet separation, and anterior motion of posterior leaflet, and decreased EF slope. So though two things we can see, decreased DE excursion and decreased EF slope. This is how it looked like. So we can see that there is a DE excursion and EF slope. Parasternal short axis view used for the planimetry, commissural thickening and calcification splitting can be seen in this view, and the appearance of fish mouth appearance can be seen is seen in this view, parasternal short axis view. at parasternal short axis view at aortic wall level. LA appendices is seen. Now we can see this, there is a LAA and there is a thrombus in LAA. Four chamber view is helpful in assessing the pressure gradient with a continuous wave Doppler tracing, pressure half time, MBVTI, MR, TR and LAA. This is four chamber view. Mean gradient is the relevant hemodynamic finding. Peak gradient is of little interest as it derives from the peak mitral velocity, which is influenced by the LA compliance and LV diastolic function. Heart rate at which the gradients are measured should always be reported. In AF, mean gradient average of 5 cycles with the least variation of RR interval should be taken, and limitation of is influenced by the transmitral flow rate, height rate, and cardiac output and associated mitral regurgitation. Measuring valve area. How do we measure the valve area, mitral valve area? By planimetry. Planimetry is considered as a reference measurement of mitral valve area. Careful scanning from the apex to the base of LV in parasternal short axis view at the level of mitral valves ensures that the area is measured at the leaflet tips. Gain is very important here, as just sufficient to visualize the whole contour of the mitral orifice. Excessive gain setting may cause underestimation of valve area, in particular when the leaflet tips are dense or calcified. Image magnification using the zoom mode is useful better to delineate the contour of the mitral orifice. The optimal timing is in mid-diastolic phase. Best performed using the cine loop mode on a frozen image. Limitation of planimetry, poor acoustic window, severe distortion of valve anatomy like severe valve calcification of leaflet tip, technical expertise, degenerative mitral stenosis. Planimetry is difficult and mostly not reliable because of the orifice geometry and the calcification, so it's not reliable in a degenerative MS mitral stenosis cases. Coming to the pressure half time. Pressure half time can be calculated. We can calculate the mitral valve area by pressure half time. So it is calculated by 220 divided by pressure half time, or 750 divided by dt. PST is obtained by tracing the deacceleration slope of the E wave on the continuous wave or transmitral flow. Pressure half time is 29% of the total deacceleration time. In patient with atrial fibrillation, tracing should avoid mitral flow from short diastoles and average of 5 cycles should be taken. Degenerative calcific mitral stenosis pressure half time is highly unreliable. Impaired LV diastolic function is likely explanation for the lower reliability of T1 to assess the mitral valve area in the elderly. So this is how we can calculate the pressure half time. Third is continuity equation. Filling volume of diastolic mitral flow is equal to aortic stroke volume, that is the continuity equation. Cannot used in atrial fibrillation associated significant mitral or aortic regurgitation. So it's not reliable in atrial fibrillation and regurgitant lesion. So continuity equation is meaning by mitral stroke volume equals to the aortic stroke volume. So this is how we can calculate. And one is PISA method, based on the hemispherical shape of the convergence of diastolic mitral flow on the atrial side of the mitral wall. Technically demanding, requires multiple measurements. Accuracy is impacted upon the uncertainty and measurement of radius of convergence hemisphere and the opening angles. So it's dependent on the expertise. PISA is meaning by proximal isovelocity surface area, and the mitral wall is calculated with PISA by the equation 2 pi multiplied by the radius square of the radius, and velocity and angle depends on angle, alpha angle divided by 180 divided by the maximal velocity. Associated lesion: LA thrombus, LA enlargement. Evaluating LA area or volume, M mode lacks accuracy because enlargement does not follow the spherical pattern of most cases. LA is spontaneous contrast, so T better better predictor of the thrombus embolic risk than LA size. T has much greater sensitivity than transthoracic echo to diagnose LA or LA appendix clot. Associated MR: rheumatic mitral regurgitation, restriction of leaflet motion, post BMB MR, leaflet tear. More than mild mitral regurgitation is relative contraindication for BMB. AS severity will be underestimated with the mitral stenosis. Severe aortic regurgitation pressure half time method is assessment of mitral stenosis is not valid. To look for rheumatic involvement of tricuspid valve, more frequently associated tricuspid disease is functional tricuspid regurgitation. Diameter of tricuspid annulus more than 40 mm seems to be more reliable than the quantitation of regurgitation to predict the risk of severe late tricuspid regurgitation after mitral surgery. So, Wilkins score included the grade 1, 2, 3, 4 on the basis of mobility, thickening, calcification, and subvalvular thickening. There are 4 parameters. So this is how do we assess the mobility, thickening, caudal involvement, and the calcification. In original study, score less than 9 optimal results, 9 to 11 is score could not be predicted outcome, and more than 8 is suboptimal results. Score less than 8 is favorable for BMB. Score more than 8 doesn't preclude BMB but will have less optimal results. So this is calcified mitral wall. Limitation of Wilkins score: commissural involvement is not included, doesn't accounts for uneven distribution of pathologic abnormality, underestimation of subvalvular disease, difficulty in determination of nodular fibrosis and calcification, and doesn't predict which patient will develop significant mitral regurgitation after BMB. So only by 2D echo doesn't require Wilkins score calculated by 2D echo only, doesn't use results or 3D or TEE. Thickening of valve leaflet. Normal thickness of mitral leaflet is 2 to 4 mm. Mitral leaflet thickening can be compared to the posterior aortic wall thickening, and the ratio given as an objective assessment. Normal mitral wall to posterior aortic wall ratio is less than 1.4. 1.4 to 2 is a mild thickening, 2 to 5 is moderate thickening, more than 5 is a severe thickening. Mobility of wall: the mobility of leaflets is assessed in both parasternal long axis and apical 4-chamber view. Extent of doming and entry leaflet can be assessed objectively with the Reed grading system. A line is drawn from the junction of the posterior wall of aortic root and the anterior mitral leaflet to the tip of mitral leaflet. A perpendicular line is drawn to the leading edge of maximum dome. Mobility expressed as the slope by dividing the height of the dome and the length of the dome. So this is how we calculate the height and length ratio. Subvalvular pathology: chordae undergoes thickening, fusion, shortening, and a calcification. Objective assessment can be done using the lung and Cormier scores. The caudal length is measured in 4-chamber and 2-chamber view. So echocardiographic grading: group 1, 2, 3. Mitral wall anatomy is the group. Group 1 is a pliable non-calcified AML with mild subvalvular disease, thin chordae tendini, chordae, and more than 10 mm long. Group 2 is pliable, non-calcified AML and severe subvalvular disease. Thickness of the chordae is less than 10 mm and less than 10 mm long. Group 3 is calcification of mitral valve of any extent as assessed by the fluoroscopy, whatever the state of subvalvular apparatus is present. Calcification. The bright echocardiographic spots over the leaflet. The presence of calcium over the commissural is an absolute contraindication for the BMB. Calcium restriction restricted to the body of leaflet is not a contraindication of the BMB for BMB. So this is MR echo score. So in commissures scores, the non-calcified fusion, anterolateral commissure and posterior medial commissures, and the MR echo scores is 1 to 2 is valvular thickening. It scores each leaflet separately. Leaflet near normal 4 to 5 mm with no thick segment. Leaflet fibrotic and calcified evenly, no thick areas. Leaflet fibrotic calcified even distribution, thinner segment and mildly thickened 5 to 8 mm. And leaflet fibrotic or calcified uneven distribution, thinner segment are near normal 4 to 5 mm. And third is the commissural calcification. Fibrosis or calcification, only one commissure. Second is both commissures mildly affected, calcium in both commissures, one markedly affected, and calcium in both commissures both markedly affected. And fourth is a subvalvular disease. Minimum thickening of chordae structures just below the wall, thickening of the chordae extending up to the third of caudal length, thickening of the distal third of the chordae, and the extensive thickening of the and the shortening of chordae extending down to the papillary muscle. So total score is the sum of the echocardiographic features. Its maximum is 16. So if the patient of rheumatic mitral stenosis comes to you, so how do we approach? If the mitral stenosis is very severe, that is the mitral wall area is less than 1 centimeter square and the pressure half time is more than 220 millisecond. Now then coming to the symptoms, if the patient is asymptomatic at the time of presentation, and the valvular favorable valve morphology is present, no LA clot, no or mild regurgitation. If the favorable wall morphology is present, then we can go for PTMC. If the valve morphology is not suitable, then periodic monitoring is required. If the patient is asymptomatic, if the patient is symptomatic and favorable valve morphology is present, yes, then we will. This is a class 1 indication for PTMC. If the valve morphology is not suitable and patient is in NYHA 3-4 symptoms with very high surgical risk, then this is a PTMC is a class 2B indication. If the valve morphology in a symptomatic patient is not suitable, then we will go for class 1 indication is mitral wall replacement. If the severe mitral stenosis case is asymptomatic and new onset of atrial fibrillation is there and wall morphology is suitable, then we will go for the PTMC. That is class 2B indication. If it's not suitable and patient remains asymptomatic, then we will periodically monitor this case. If there is a progressive MS, that is a mitral wall area is more than 1.5 centimeter square and pressure half time is less than 150 millisecond, symptomatic with no other cause, pressure PCWP is more than 25 millimeter Hg with exercise, then PTMC is a class 2B indication. If the PCWP is less than 25, and we can do the periodic monitoring of this case. So this is heavily calcified mitral valve. This is the classically mitral stenosis, and this is the how do we calculate the pressure half time. So coming to the second important echo assessment of mitral regurgitation. So we have already discussed the anatomy of mitral wall. This includes the annulus, leaflet, chorditendini and papillary muscles. So Carpenter classification of mitral wall. There are two leaflets, mitral wall, anterior and the posterior. Carpenter divided it into P1, 2, 3 and 4, and anterior leaflet 1, 2, 3. Carpenter classification used by the ASC and SCA and divided the PML into P1, that is the lateral most, P2 is the middle, and the P3 is the medial scallops, and the AMBL into corresponding A1 is the lateral, and A2 middle, and A3 is middle most portion. So how it look like? A1 and A2, if we take the plaques view, so A2 and P2 scallops are visible. Second is in figure B, there is a A1 and P1 is visible. This is how do we do it? Tilting the probe towards the aortic wall. If we tilt the probe in a plaques view to the aortic wall, we can see the A1 and P1 scallops. A3 and P3 tilting the probe towards the tricuspid wall, so we can see the third scallops of the mitral wall. So coming to the classification of Carpenter classification, most commonly used for the assessment of grading the mitral regurgitation. So dysfunction, lesions and etiology. So type 1 is a normal leaflet motion. There is a normal leaflet motion, and lesions are annular dilatation and leaflet perforation or tear. And etiology is most commonly dilated cardiomyopathy, may be endocarditis lesion for the perforation and tear. Type 2 is excessive leaflet motion. Leaflet may prolapse. Lesions may elongation, rupture of the chordae, or maybe rupture of the papillary muscle. Degenerative valve etiologies are degenerative valve diseases, fibroelastic dysfunction, fibroelastic deficiency, Warlow disease, Marfan disease, endocarditis, trauma, and ischemic cardiomyopathy. Type 3 is again divided into A and B. Type A includes the restricted motion diseases, both in diastole and systole. Type 3B is restricted leaflet motion only in the systolic phase. So coming to type 3A, leaflet thickened, restriction, leaflet calcification, caudal thickening, restriction fusion and commissural fusion. And the etiology most commonly is rheumatic heart disease and carcinoid heart disease. Type 3B, most commonly we encounter during day-to-day practice is type 3B lesion, that is left ventricle dilatation, aneurysm, papillary muscle displacement due to ischemia or later on dilated cardiomyopathy. So morphological parameters of ischemic mitral regurgitation is a global LV left ventricle remodeling. LV diameter, LV volumes, and sphericity index is length by maximum length by minor axis. Mitral regurgitation. The characteristic of true mitral regurgitation, one is flow convergence. There are 4 hallmarks. It is flow convergence, flow acceleration, turbulence, and downstream. So flow convergence is assessed by PISA method. Flow acceleration is assessed by vena contracta, and turbulence by the JIT area or LA area, and downstream by the pulmonary vein flow reversal. So characteristic of true MR is flow convergence, proximal flow acceleration, ejection flow with a vena contracta, downstream appearance blood ejected through the constraining orifice and confined to the systole. Doppler signals appropriate in color. So echo Doppler associations with mitral regurgitation, say anatomic and the Dopplers. Anatomically, we can see the chambers, left ventricle dimension, size, left atrial dilatation, left ventricle volume, and stroke volume, valve perforation, and flail or perforated leaflet. In Doppler view, Doppler color flow, jet area indexed to left atrium, central versus eccentric jets, vena contracta with proximal iso, velocity surface area, size, qualitative, volumetric flow, regurgitant flow, effective regurgitant orifice, and pulmonary vein flow reversal is spectral forward flow calculation at the mitral annulus and signal density. So assessment of mitral severity by the colored Doppler, color flow Doppler. Most common way of assessment severity. As the severity increases, the extent of the jet into LA also increases. Large range of variability. This is less accurate method, but this is most commonly used. For a similar severity, patient with an increased LA pressure or eccentric jet that hugs the LA wall, or in whom the LA is enlarged, may exhibit a small jets area than those with a normal LA pressure and size, or with the central jets. So this is trace and mitral, mild and moderate and severe regurgitation. This is Flack's view, assessing the mitral regurgitation. So, key point, color flow area of the regurgitation jet is not recommended to quantify the severity of mitral regurgitation, only for the detecting mitral regurgitation, that is a qualitative. A more quantitative approach is required when more than a small central and mitral regurgitation jet is observed. So, characteristic of mild MR, the velocity is less than 20% of LA area, LA jet, and up to 20 to 40% area is moderate MR, and more than 40 is severe MR. Not all color Doppler signals appears within a LA represents mitral regurgitation. What is the meaning of this dictum? Several potential sources of color Doppler flow signals in LA. Normal posterior motion of the blood pools caused by the mitral valve closure, reverberation of from the aortic flow, normal pulmonary vein flow, atrial blood pool motion of overall low velocity inappropriately visualized because of the inappropriate gain and an aqueous limit. So MR when suspected to be confirmed in a multiple views. So this is normal posterior, picture A shows a normal posterior motion of the blood pool caused by the mitral valve closure, and B is showing there is a mitral regurgitation, jet flow, color artifact arising from the aorta in a picture C, and picture D, prominent pulmonary vein flow in the LA in systole. So these are all where we can miss or assess as a mitral regurgitation. Vena contracta width, what is the meaning? It is the area of jet at the levels the regurgitant orifice. It reflects the regurgitant orifice area imaged in a view perpendicular to the commissural line. A vena contracta with less than 3 is a mild MR and more than 7 is severe MR. The concept of vena contracta is based on the assumption that the regurgitant orifice is almost circular. The orifice is roughly circular in primary MR, while the secondary MR, it appears to be rather elongated along the mitral coaptation line and non-circular. So in secondary MR, it is non-circular, and while in a primary MR, is roughly circular. So this is there is the arrow indicating the vena contracta. When feasible, the measurement of vena contracta is recommended to quantify mitral regurgitation. Intermediate vena contracta value 3 to 7 mm needed a confirmation by the more quantitative method when feasible. And vena contracta can often obtained in eccentric jet In case of multiple jet, the respective values of the vena contracta width are not additive. The assessment of vena contracta by 3D is better for evaluation of mitral regurgitation. So this is apical 4-chamber view. So there is a large central jet and large eccentric jet we can see. This is semi-quantitative assessment of mitral regurgitation severity using the vena contracta. The 3 components of regurgitation jet, flow convergence, vena contracta and jet turbulence are obtained. So what is PISA? Proximal isovelocity surface area. As the blood approaches a regurgitant orifice, its velocity increases, forming the concentric, roughly hemispheric cell of increasing velocity and decreasing the surface area. The flow convergence method, the most recommended quantitative approach whenever feasible. A 4-chamber view is recommended. The area of interest is optimized by lowering the image depth and reducing the Nyquist limits to 15 to 40 centimeter per second. The radius of PISA is measured at mid-systole using the first aliasing. Regurgitant volume and effective regurgitant orifice area are obtained using the standard formulas. So this is in this diagram the 3D shape of the flow convergence in functional, and the functional there is a hemi-elliptical, and organic mitral regurgitation is hemispheric. So when the shape of the flow convergence zone is not hemispheric, the PISA method may underestimate the degree of functional mitral regurgitation. So this is a apical 4-chamber view. This is the regurgitant jet of mitral regurgitation, and this is how we zoom it, and we will calculate that TVI and effective regurgitant orifice area and regurgitant volume. So how do we calculate it? So we calculated first is effective regurgitant orifice area. So it's equal to the flow divided by the peak velocity. And then how do we calculate the flow? Is by the 2 pi r square into velocity divided by the peak velocity. And so we can calculate the effective orifice area, regurgitant area. And regurgitant volume is calculated by effective regurgitant orifice area multiplied by the VTI. So effective regurgitant, as per we can see that if they in the case of severe primary mitral regurgitation, the effective orifice area is more than 40 millimeters square and regurgitant volume is more than 60 ml. While in a severe secondary MR, there is a effective orifice regurgitant orifice area is more than 20 millimeters square, while the regurgitant volume is merely more than 30 ml. It is a severe mitral regurgitation. So key point, when feasible, the PISA method is highly recommended to quantify the severity of mitral regurgitation. It can be used in both central and eccentric jet. Effective orifice area of more than 40 mm square and a regurgitant volume of 60 ml indicates a severe mitral regurgitation. In functional ischemic mitral regurgitation, ERO more than 20 millimeters square or regurgitant volume more than 30 indicates a subset of patient with increased risk of cardiovascular events. So this is a case of secondary MR and in the ischemic mitral regurgitation. So pulse Doppler, how it is helpful, use as an additive to alternative method, especially when the PISA and vena contracta are not accurate or not applicable. So MR volume is calculated by the total stroke volume minus the systemic stroke volume. So MR volume is calculated by mitral flow minus aortic flow outflow, mitral inflow minus aortic outflow. Mitral inflow, how do we calculate, is by the TVI into CSA, and in aortic outflow is calculated by TVI and again velocity into the area, multiplied by the area. So cross-sectional area of mitral annulus is assumed to be the circular, and the calculator is pi r square, where the r is the diameter measured in the apical four-chamber four-view divided by the 2. Pulmonary venous flow. In a normal individual, a positive systolic wave S followed by the smaller diastolic wave D is classically seen in the absence of diastolic dysfunction. With the increasing severity of mitral regurgitation, there is a decrease of S wave velocity, and in case of severe MR, S wave becomes frankly reversed. So there is a reversal of S wave in severe mitral regurgitation in pulmonary venous flow. Evaluation is best performed by the transesophageal echocardiography with the pulse Doppler sample placed 1 centimeter deep into the pulmonary vein. This is important. And sampling through all pulmonary veins is recommended. Another important thing. So we will put the sample at, we will take the sample at 1 centimeter deep and through all pulmonary veins. Atrial fibrillation and elevated LA pressure leading to the blunt forward systolic pulmonary vein flow. So this is a normal pulmonary vein flow pattern. Second is a blunted forward systolic pulmonary vein flow in a patient with a moderate mitral regurgitation. And third, there is a reversal of S wave. So reverse systolic pulmonary flow in a patient with a severe mitral regurgitation. So here we can see that S wave is reversed here. Continuous wave Doppler of mitral regurgitation. The peak mitral regurgitation velocity by the continuous wave Doppler typically ranges between 4 and 6 meter per second. This reflects a high systolic pressure gradient between the LV and the left atrium. The velocity itself does not provide useful information about the severity of mitral regurgitation. The signal intensity, jet density is important. Of this continuous wave envelope of mitral regurgitation can be a quantitative guide to mitral regurgitation severity. A dense MR jet signal with a full envelope indicates a more severe MR than a faint signals. The continuous wave Doppler envelope may be truncated with a triangular contour and an early peak velocity. This indicates an elevated LA pressure and prominent regurgitation pressure wave in the LA during the severe mitral regurgitation. So this is we can see the faint envelope and a dense envelope. So last one shows a severe mitral regurgitation. So value of mitral regurgitation, mild, moderate and severe regurgitant volume is 30 ml, regurgitant fraction less than 30, and regurgitation orifice area is less than 0.2 centimeter square. In moderate is in the severe grade, there is a regurgitant volume is more than 60 ml, fraction is more than 50%, and regurgitation orifice area more than 0.40 centimeter square. So this finishes with the mitral wall assessment by the 2D echocardiography. Thank you.